tough. But so we're going to just dive into ECMO a little bit. I think it's very difficult to get to the end game of patient selection matters without understanding a little bit about what's going on in the ECMO world and where things started and where things have ended up. So again, no relevant disclosures for this presentation. Consulting, grant, research support from a few corporate sponsors, but none that have anything directly to do with this presentation. So a few basic abbreviations just to make some of the slides make sense. ARDS is acute respiratory distress syndrome, conventional CPR, CCPR, extracorporeal membrane oxygenation, ECMO, our topic for the evening, LVAD, LVAD, left ventricular assist device, PGD, primary graft dysfunction, so that would be such as a transplanted heart that isn't working optimally after implantation. Post-cardiotomy shock, patient that's had heart surgery, doesn't want to come off cardiopulmonary bypass without atypical support. VA, meaning veno-arterial, as in veno-arterial ECMO, and VV, as in veno-venous ECMO. When we look at active ECMO centers, this slide depicts 1990 through 2014. We see that starting in about 2004, 2005, there was a significant upsweep in the curve to where that now there are quite a number of centers up and running. It's been an exponential increase up through 2014, 2013, at which point it seemed to level off. And I think part of that is because it does require a certain amount of infrastructure to be able to support an ECMO team. If you look at trends changing over time, even though this is a very busy slide, look to the far right and you will see that the two groups that have increased most markedly as one gets to 2014, 2015 is the adult cardiac population, 16 years of age and older, and the adult pulmonary population. Both of those are outlined with the red brackets you see on the slide. If you look at this another way, you see this exponential upsweep beginning about 2007, 2008 in the adult curve shown on the bottom dashed line. If you look at cumulative survival in adult respiratory, not cardiac, but adult pulmonary support, we see that the survival rate has been relatively flat with a mild upsweep starting in about 2007, 2008, but really hasn't significantly changed over the last decade, decade and a half. If we look at an analysis of cases and mortality, this is an interesting way to look at it. Looks at it over a long period of time, 1989 to 2013, but then breaks down into a more recent cohort of 2008 to 2013. This was published in AJRCCM in April of 2015. And what one sees is that if one looks at the top part of this graphic or a set of tables, one sees that as you increase the number of ECMOs performed at a hospital, you typically see a drop in the O to E ratio, i.e. an improvement in outcomes. If you look at the more recent era, 2008 to 2013, you see less of a change except in the adult area, but in centers that do 15 plus ECMOs. It's less dramatic than it was in the longer cohort. And I think that's because things have gotten better and more predictable. Here you see in a very different presentation, but similar data, that outcomes did change with number of cases performed, i.e. hospital volume, across neonate, pediatric, and adult if one looks at 89 to 2013. And if one goes to 2008 to 2013, one sees less dramatic changes except in the adult population when you're doing 30 or more cases. This is, again, adult respiratory failure. You see that, that in 2014, the number had gone up quite significantly. Pediatric respiratory failure, again, numbers increased steadily through 2013 and appeared to plateau at 2013, 2014. Neonatal numbers, however, appear to have gone down since the mid-90s and kind of plateaued in the 2003 to 2013 range, but not necessarily the upsweep that we see in the other patient populations. And all those slides serve to show that the demand is increasing. So if we're going to use it, and we're using it more and more often, we need to understand how best to use it and how to use it most effectively. So what are the realities of ECMO? Well, some of these are very obvious, and some of them we need to remind ourselves about on a daily basis. It's a supportive therapy. It's not a curative therapy. It's supporting the patient. You need an underlying condition that can be reversed. Success rates and issues with each disease process differ as ECMO therapy is used. It's a team approach. It's a multidisciplinary approach. And when you take it out of the multidisciplinary realm, it becomes very haphazard, and you end up with a lot of patients on ECMO that perhaps you really aren't doing any favors. And you really don't need to go there if there's no end game. If there's nowhere to go with the patient and the patient's dying, sometimes death with dignity is better than a prolonged run on ECMO, using a lot of resources that really aren't going to change things. So if we look at veno-venous ECMO, so these are patients that require partial support, primarily from an oxygenation point of view. We find that common indications include severe viral and bacterial pneumonias, respiratory distress syndrome, persistent pulmonary hypertension of the newborn, ARDS, status asthmaticus, massive pulmonary hemorrhage, and severe pulmonary contusion, where time is needed for these things to heal. Common VA ECMO indications include cardiogenic shock, an inability to wean from cardiopulmonary bypass after cardiac surgery, sepsis with profound cardiac depression, myocarditis, drug overdose causing cardiac depression, and cardiomyopathy as a bridge to cardiac transplant or long-term durable assists such as LVAD support. Pulmonary embolism is another indication for VA ECMO. If we look at percutaneous cannulation of patients, one of the things that teams need to become familiar with are stiff guide wires, because oftentimes you're putting large cannulas into veins, and that requires dilating a tract and maintaining that tract, and a lot of these patients aren't exactly slim and fit. So there's a distance with which you need to be able to get that catheter to go through. Just a schematic of VV ECMO. I think the perfusion audience online are very familiar with what this looks like, and sometimes it's a warm, fuzzy feeling, and other times they may want to run the opposite direction because they realize their schedule is about to be disrupted. This is an example of percutaneous VV ECMO. This is with an Avalon cannula, which is a cannula that has a side hole that directed at the tricuspid valve, and then more distal holes, both in the SVC and IVC, to collect blood, oxygenate it, and then give it back aimed directly at the tricuspid valve. There's another cannula out, Joe and I were talking about earlier, that actually separates the return from the intake and has a limb that goes out into the pulmonary artery, thus providing a little better separation and less mixing. But either way, it's a very big cannula that typically is put in through an internal jugular approach to achieve the outcomes. This is a schematic of VA ECMO. I think if we look at this, there's a central cannulation strategy. Most teams that cannulate patients centrally for VA ECMO cannulate them with tunneled cannulas such that the chest can be closed if the patient needs to be on ECMO for more than 24 to 48 hours. I also find that tunneling the cannulas facilitates a more occlusive surgical grade dressing. Personally, I use a wound vac for that. Provides a great dressing, doesn't get breached, and works very well, but it does require you to tunnel your cannulas to get that seal. Mm-hmm. This particular schematic here shows a graft having been sewn onto the aorta with a cannula going in the graft for arterial return, and it shows a large multi-stage venous cannula in the right atrium for removal of blood to send it to the ECMO circuit. There are multiple cannulation options, i.e. cannula options for this. I personally prefer to use a 19 femoral type cannula placed in the either the aorta directly or in a graft. And I will oftentimes use a 25 multi-stage femoral cannula just to have more cannula to tunnel, positioning the holes in the right atrium as well as the IVC. This shows a commonly performed procedure now for VA ECMO, which is percutaneous peripheral cannulation. Chose this picture because it depicts a small patient, very small. You'll notice that's a 14 French arterial cannula. That should give you an idea of how small. But it also shows other very important adjuncts to the cannulation, i.e. an antegrade femoral cannula to provide blood flow to the distal limb on the arterial cannulation side for VA ECMO. It also shows that in the small patient, they've chosen to place the venous cannula on the left, thus not impeding both arterial inflow to the leg and venous outflow from the leg. Mm-hmm. And I think when you have smaller patients, especially younger patients with very vasoactive arteries, this cannulation strategy makes a lot of sense. Well, we have found that in percutaneous cannulation for VA ECMO, bleeding is minimized, transfusions are minimized, and in the end, you end up with a better chance of getting the patient through it. Same thing's true, as I alluded to, with central cannulation. If you can close the sternum and have your cannulas tunneled, you're going to have less bleeding and fewer infection rates, a lower transfusion rate. There are ECMO circuits designed for transport and or ease of use. This shows the Mackay CardioHelp system. It's compact. It weighs about 10 kilos. Rapid prime. Basically follow the instructions and you can be primed in less than 5 minutes. And it has a 90-minute battery life. It's ideal for transporting patients in a spoke and hub model where patients may be urgently cannulated for a cardiomyopathy or post-cardiotomy failure and need to be transported to a quaternary care center for someone like myself on the receiving end. Again, the cannulation principles are exactly the same. It's just a way to hook things in. Echo plays a pivotal role in ECMO. It helps with patient selection, helps guide you with regard to what you might need. Is this a primary cardiac problem? Is it a primary pulmonary problem? Which direction do we go with this patient? It helps with cannulation and initiation of flow. If you're doing a femoral cannulation, you need a nice bicaval view to ensure that you're optimally placing your femoral venous cannula so that the tip of the cannula is a couple of centimeters up the superior vena cava so that you fully optimize drainage. Because in a recovery mode, you have to maintain appropriate drainage. It helps monitor ECMO response. It helps detect complications. Sometimes those complications might include thrombus, intracardiac thrombus. Sometimes they might just indicate that you're not really draining the heart as well as you should and you're not really setting that heart up for recovery. It helps with recovery and weaning of support as well. So this is a nice echo picture that shows in the left frame just a picture without color. But what you see is the aorta headed off toward the 2 o'clock position, aortic valve kind of in the middle of the screen, and that big circle underneath the aortic valve is the dilated left ventricle. In the illustration to the right, or figure to the right, they've added color, and what you see is we have significant mitral regurgitation to go with that dilated ventricle. This patient is not being set up for recovery. You need left ventricular decompression. You're also flooding the lungs. It's just not a good setup to get this patient off ECMO and into a good outcome.
So would you put an Impella in that?
So I would do one of two things. If they were centrally cannulated, I would put a LV vent in. If I would consider an Impella, I would also consider a tandem type catheter across the interatrial septum. I think most people today tend to be favoring the Impella option, but it's certainly not an inexpensive option. And that's why I think if your chest is open and there's no reason not to, then going in and putting in a LA-LV vent is not a problem. But you do need to do something, and I think that's your point.
Most of ours are most of ours are going to be not central and peripherally cannulated. Most of ours are going to be that way. So if the chest is already closed, but you have somebody in refractory lethal arrhythmia, can't their PEA or whatever it may be, took them to cath lab, they can't figure out what to do for right now. They're on VA ECMO, but the heart's distended. I mean, that's really, our only option. Well,
and honestly, a lot of these patients today come in with a Impella.
Really?
So they come in, they were intercepted at an outside hospital. That's what they have to offer in the cath lab there, so that's what was placed. And they may or may not put them on ECMO at that hospital. They may try to send them in as good a shape as they can without ECMO, or they may go ahead, after the Impella doesn't fix the problem, go ahead and go to VA ECMO. But then, yes, you would leave the Impella in. When do you see ECMO? Well, you really need a sustainable EF. You need something you can work with, and ideally it would be greater than 35 to 40%. Now, that certainly isn't the case every time. We have some heart failure patients that you're not going to get to that point, but you need at least the ability to manage the patient and prevent end organ failure after weaning from ECMO and get them to a point where you can get them out of the hospital and maintain them. You need absence of LV dilatation. You're not going to win the game if you've had high LV pressures and subendocardial ischemia. You're not going to wean off ECMO. And you need to make sure there's no evidence of cardiac tamponade. You need to be set up for success and not set up for failure. Highest levels of evidence for ECMO on the respiratory side are ARDS, bridge to lung transplant, and graft dysfunction after lung transplant. Those are on the pure pulmonary side. On the cardiac side, MI-associated cardiogenic shock, fulminant myocarditis, nothing much worse than a patient that presents with giant cell myocarditis and is rapidly deteriorating hour by hour, if not minute by minute. Post-cardiotomy cardiogenic shock, I love spell correct, it corrected it yet again. Emergent CPR with emergent cannulation and graft dysfunction after heart transplant. There are any number of complications, but most of them have to do with inappropriate clot and inappropriate bleeding. Inappropriate clot, inappropriate bleeding, they lead to transfusions. That doesn't make the kidneys very happy. It increases your infection risk and increases your likelihood of having mechanical complications. If we look at complications shown on this slide, we see that survival, it's not great to begin with, i.e. it's not 60, 70, 80%, but with complications, it varies between 14 and 45%, with CNS hemorrhaging being the most onerous complication. So who do we put on ECMO? That's the real question.
Everybody.
And you get an ECMO.
Well, I'm just
Look under
thinking
your
that
chairs.
I'm just thinking that the perfusionists out there listening are not going to be happy with that response.
Oh, God. Yeah, I know. The numbers are going down. They're closing out the YouTube now. Come back.
And I did borrow the slide, but I'll fully admit to that. But I love it. Basically, it's as clear as mud. Just do what the signs tell you. So who you put on ECMO changes with the times. Prior to the 1990s, it was basically if you're really, really dying and your mortality is above 75%, then give ECMO a whirl. But you're probably not going to do well, so you need to be pretty sure you're not going to do well before you go to ECMO anyway. By the mid-90s, the mantra was really something like sick, but not too sick. So maybe 50% mortality to 75% mortality, but not too sick and not too well. Really, it's evolved to an inadequate response to ongoing maximal medical therapy. High risk for imminent death, but a reasonable success for recovery. You need to have an end game that's possible. There are no absolute, all-inclusive, evidence-based parameters. I can't give you a list. There has to be some degree of common sense applied in this whole equation.
Yes, because what you said, in terms of, patient is sick but not too sick and reasonable chance for potential survival, it can be very subjective.
Yes.
So
That's why a team approach is very helpful.
Yes, good point.
So let's start first with patients that probably should not go on ECMO. So in the neonate, if your gestational age is less than 34 weeks, 32 weeks, probably not a great idea. Outcomes probably aren't going to be that great. If you're over 65 years of age, over 70 years of age, probably should think twice. Need to make sure that you have an end game. You at least need to be able to get, let's say if it's for cardiogenic shock, the patient needs to be at least a VAD candidate. You need to be able to get them to that point. Low birth weight, less than 2,000 grams, high BMI, weight over 140 kilos, you're probably going to have problems. You're probably going to have infection-related problems, bleeding-related problems. Lethal malformations. If they're lethal malformations, you're not going to fix the end game. Prolonged mechanical ventilation. If you've been on the vent for over 14 days and you're not a lung transplant candidate, that's not a good time to be starting ECMO.
And we talked about that. I think that's very generous.
Irreversible lung disease in a non-transplant patient. There's no end game. Irreversible pulmonary hypertension, chronic, severe. You need an end game. Uncorrectable cardiac lesions in a non-transplant candidate. Unwitnessed cardiac arrest. You could, in theory, put anybody in the field on percutaneous ECMO. If you wanted to set up your teams and send people out, there are programs that have set up teams to go out and percutaneously put people on ECMO in the field.
In Paris and in Ann Arbor, Michigan right now.
Yes. But it's a very specialized approach, and if you start doing that for unwitnessed cardiac arrest, your numbers are not going to look very good. I think conservative numbers would say CPR prior to the initiation of ECMO that's over 60 minutes with ACLS protocol ongoing should not go to ECMO, and greater than 15 minutes if it's bystander CPR without ACLS protocol. Aortic dissection, not going to play well. Severe aortic valvular insufficiency, you're not going to be able to perfuse the patient and you're not going to be able to recover the heart or the lungs. Non-recoverable neurologic disease, recent neurosurgical procedure or intracranial bleeding within the last 10 days. You have to be able to anticoagulate these patients or you're going to trade one problem for another problem.
So you wouldn't recommend Angiomax for an ECMO patient?
I probably wouldn't recommend Angiomax for intracranial bleed less than 10 days old.
Okay, well, I thought it was contradictory. The one that's for systemic anticoagulation, the 100.
Well, but you have to be able to anticoagulate patients to some extent. Intracranial hemorrhage greater than grade 1, you would need to still watch that patient, if it were a grade 1 for conversion to a more severe bleed. And uncontrolled bleeding or coagulopathy, it's only going to get worse. So if you're starting out at that point, it's not a good end game. Again, significantly immunodeficient patients, absolute neutrophil count less than 400, infection rate is going to be very high, and their likelihood of surviving ECMO is probably going to be less than 30%. Active malignancy, graft versus host, we talked about, with no end game, or bone marrow transplant patients who have cardiopulmonary failure in the early phase, they're going to be at extremely high infection risk. So let's move on to the ones that require you to scratch your head a little bit and have a second thought. Mechanical ventilation for over 10 days, if not a lung transplant candidate. And I think, or in an earlier conversation with Joe, he was favoring 7 days, but I think the literature would certainly say 10 days. But you're approaching that 14-day cutoff, and really are things going to change a lot between day 10 and day 14. The point being, the longer you're mechanically ventilated, the less likely you are to benefit from converting to ECMO. Multiple organ system failure, major immunodeficiency, severe coagulopathy or bleeding, but you think you can manage it. Trauma with multiple bleeding sites, again, you really have to be able to manage it. Pregnancy, severe right or left heart failure without long-term options such as LVAD, TAH, which would require that you be a transplant candidate, and cardiac transplant candidacy. Special circumstances, obesity. It's interesting. Most of the literature would say consider central cannulation, but on the other hand, if you can maintain stability of your cannulae, percutaneous peripheral cannulation may actually give you less bleeding. On the other hand, you really like to keep things out of the groin on patients where it's difficult to maintain hygiene. Myocarditis or acute cardiomyopathy with chance for recovery, you want to definitely ensure adequate RV and LV emptying. Pulmonary hemorrhage, you have to figure out what you're going to do with your anticoagulation strategy. You have to not make things worse and allow those lungs time to heal. Sepsis with vasodilatation can be problematic. It's oftentimes hard to maintain good vasomotor tone, to get good response to vasoactive agents, and maintain renal perfusion. It's just very difficult. In the pediatric population, congenital diaphragmatic hernia, you want to make sure there's adequate lung tissue for survival before you go to ECMO. You want to make sure there aren't any other critical defects present. Typically, you want to be able to have a SAT of 85% and a PO2 of over 70. And you want to make sure you really collaborate with all the teams involved, neonatology, pediatric surgery, to ensure that this really is a road that leads somewhere other than disappointment. Pertussis, certainly not something as an adult surgeon I see a lot of, but there can be a 70% mortality associated with pertussis, higher in infants, higher in fulminant pertussis, and it's an inflammatory state that is oftentimes hard to manage, and so you're looking at a 30% or less survivorship. Again, it's a high-risk population. In 2016, this slide kind of summarizes outcomes, and what you'll notice, I'm going to just focus at the adult side, if I can make the pointer work, there we go. So, at best, we're at 58% for respiratory problems requiring ECMO, 41% for cardiac, and if the patients go emergently with CPR, we're down about 30%. So we're still, under 60% survivorship. So you really want to make sure you're picking patients that have a high likelihood of benefiting from the technology. There are ethical challenges. Traditional definition of death usually includes cessation of cardiopulmonary function. Gee, we're doing that for you. So that's kind of a tough one. Informed consent is a bit of a conundrum. You go tell a loved one that their loved one is going to die if you don't do something, and they have a 20, 30, 40% chance of making it if you do this truly emergent thing. They're probably not going to look at you and say, don't do it. So it's very hard to get any answer other than please go ahead. There's not a lot of time for detailed discussions of the implications of being on continuous support. It's very difficult sometimes to discuss we're on this bridge, but it's really a bridge to nowhere. And making sure that you have that conversation with families as early as you possibly can, and making sure that you don't put people on ECMO who are never going to get off that bridge to nowhere is paramount to these discussions. With VV ECMO, there are 3 potential outcomes. There can be recovery of respiratory function, there can be death, or there can be survival with irreversible end organ damage. Recovery is very unlikely after 4 weeks of support. And the complications go up exponentially after 14 days of support. So if you're at 12, 13, 14 days of support and you're not making progress, it's really time to make sure the family and other team members understand this, because it can be equally hard for the nurses taking care of the patient every day, the physicians that have known that patient for 30 years. It's tough. It's tough to stop sometimes. With VA ECMO, it's complicated if there's no recovery or prolonged ongoing support. If patients are not candidates for VAD, total artificial heart, or heart transplant, they either have to recover or you have no option. A lot of these patients really, at best, would be candidates for a VAD, but then you need the right side of the heart to work. So you have to set them up with strategies to adequately decompress the LV and the RV, or left ventricle and right ventricle. You really want to avoid transfusion and or infection-related complications, thus percutaneous cannulation strategies and or a tunneled central strategy where you can close the chest and minimize the likelihood of that chest having to be open for 5, 7, 10, 14 days is very important. Economics. All of us are faced with economic discussions with our hospitals, with insurance companies. So the CSER trial looked at 180 patients, and they were randomized for ARDS management. So this was VV ECMO versus optimal medical management. The cost for VV ECMO was about $30,000 per quality adjusted life year, which interestingly enough is less than that for hemodialysis. And thus it was felt for ARDS in a VV ECMO setting to be cost effective. But when one looks at it further, this study actually looked at 9,000 admissions over 98 to 09. So
Daily hospital cost.
yes, average daily hospital cost $40,000. Average total hospital cost $344,000. The post-cardiotomy shock cohort was the most favorable with the lowest resource utilization. And, one could infer that, it was recognized early. Measures were taken to ensure that everything possible was done from the onset. And it seems a favorable group of patients to have ECMO support for. Cost analysis is less clear for VA ECMO than it is for VV ECMO. And there's this disproportionate growth, as I showed you, for non-post-cardiotomy cohorts, resulting in worse outcomes and cost effectiveness. Because you'll notice in all those outcome slides I showed, adult cardiac is lumped into one category. So in conclusion, it's been about a 45 plus year evolution. Designs have changed. ECMO today doesn't look like ECMO of 40 years ago. Technology has changed. If you had told my colleagues from 30 to 40 years ago that there would be a device that looks like CardioHelp, they would have laughed you right out of the room. Patient selection has gotten more purposeful and more of a multidisciplinary discussion. Cannulation techniques have clearly evolved. Percutaneous techniques are the standard today, whereas even 10, 12 years ago, there were a lot of open femoral cannulations performed with a lot of bleeding oftentimes associated with them. There are adjunct devices to help with things like LV decompression. We mentioned the Impella device, certainly a possibility. It's a nice transcutaneous, transarterial device for that. And management strategies have evolved to where it's not just, and I use the word just loosely, but it's not the surgeon du jour or the doc du jour, but rather it's a robust team of individuals, truly manage them with some evidence-based medicine behind their management strategies. Outcomes have improved, indications have expanded, but at best, the results are only moderately successful. Ethical issues persist, and we continue to need to kind of deal with those on a daily basis. And I think patient selection helps us deal with those a little more proactively. ECMO is a program. It has to be multidisciplinary. The surgery team can't do it and then expect the heart failure team to fall in line from a cardiology point of view. The pulmonary medicine guys can't do it and expect heart failure cardiology or surgery just to follow the lead. There has to be a lot of discussion because each team has to be set up for success. In the end, patient selection does truly matter. And with that, we'll entertain some questions.
That was great. I truly enjoyed that. And some really provocative, interesting data on there. I want to loop our additional guests in to this conversation. I've got a lot of technical questions I want to cover. We're going to, I think, open the phone lines at this point as well, and then kind of get to those technical things. But, from a staffing perspective and a cost perspective, we'll start with Kristen over here. You saw that $40,000 a day. Mm-hmm. That's an average daily charge. Now, I guess that's an average, and it may be more or less depending on your particular institution. But I know that what we're looking at, because I've been looking at the numbers very carefully, from just my perspective, for us covering the cases in your ICU, we're taking 30% of your DRG at day 14. So that's where that is, and that's every hospital that we go to. And that's what it costs. Mm-hmm. What is your view on the perspective of transitioning the at the bedside care of the ECMO to the nurse, if trained properly with appropriate training and some oversight or some availability of a perfusionist readily able to come in and assist to control those costs, but yet keep perfusion, in terms of setting the thing up, making sure that it's running well, doing rounds on it, continuing education, competencies, and that kind of thing. What is your view on the nurse at the bedside responsible for that ECMO?
Well, presently, that's not our current state, as you know. I think with the right training, it's definitely something that's possible. Mm-hmm. We do continuous dialysis. My bedside nurses do continuous renal replacement therapy.
That's right.
With the right training and the right support.
I did some of that training.
So I do think that it is possible. I think you've got to have the right staff. That training has to be very, very specialized. Mm-hmm. And then I think my concern would be, how do you keep these people competent? We do ECMO at our facility in the ICU. but it's not something that we're doing on even a monthly basis necessarily.
That's right.
So
It
that is where
it's
my
seasonal.
concern
Hit and
would
miss
lie.
and seasonal. That is an excellent point. But
So let's back up a second. I want to take you off the hot seat for a second. I think there are many models for ECMO management. One model is perfusion. There's no question it places a significant drain on the ability to provide the other perfusion-related services if perfusion is sitting ECMO 24/7.
Well, I mean, my favorite saying is we're one epidemic away from not being able to provide care. It's just simple math.
The other model is a nurse/respiratory therapy model with critical care oversight.
Mm-hmm.
Those models exist.
Mm-hmm.
And, in some institutions, they seem to work as well.
Nurse ECMO specialist.
Nurse ECMO specialists. And then and a lot of those nurses were ICU nurses, such as nurses working in your unit. And then there's the model in between, which is a model where perfusion oversees a team of ICU nurses that are ICU nurses, but also have additional responsibilities of just also watching, not just, but also watching ECMO on their patients that are on ECMO. I don't think anybody has figured out the perfect model from a manpower point of view. And I think to your point, it is difficult to maintain competencies. And so I think there is a huge opportunity out there for figuring out how one does that.
Mm-hmm. Well, let me get Kara and Katie involved too. From an educator's perspective, we're talking about competencies, and the training for something like this, which I feel like ELSO has a training, ProCirca has a training, ECMO Advantage has a training. We too plan on having nurse ECMO specialist training available at a different location than this with a simulation lab. And, it's a 3 to 5 day, depending on what level you're looking for, to teach nurses how to do this. But from an educator's perspective, when you only do 2 or 4, perhaps in your particular center, a year, perhaps more if it's an off year where we have a big flu epidemic, is that enough? How do you deal with that? How do you deal with it from a hospital risk management perspective?
I think it's really hard to maintain competency and when you're doing such low volumes, for sure.
But granted, they're low volumes, but remember, they're long term. They're several days. I mean,
correct.
So that is a bit of a difference.
So with any of our training programs, what's really challenging is when you go through training and then don't see it again for 6 months.
Mm-hmm.
Full term,
so
if you don't use it, you lose it.
Right.
It's completely.
And you also think of what is competency. It's not just having skills and the knowledge, it's also having the attitude behind it, right? To confidently be able to take care of that patient as well. And I think some of our nurses would be excited at the thought of running ECMO while others would be scared to death.
Mm-hmm. Yeah.
It just depends on that core team of nurses that receive the training and actually feel comfortable with it.
Exactly, but if they're put in a category that maybe came with an increase in their hourly rate while caring for those patients, or just for having that potential additional responsibility, I mean, when I'm looking at it from a value analysis to the hospital, I mean, the savings can be very significant. The cost of, the training is, nothing's free, so the training is going to cost money. But, when you take the cost of training, you take the cost of continuing education, you take the cost of competencies, and you put that next to the cost of me sitting in your ICU at the bedside, diligently just staring at it the entire time, there's no comparison. It is very, very, very expensive versus really much more affordable. And I mean, I think these are just these are just realities that we're going to have to face and address. Carrie, you had anything to add to that?
You know, you talked about different categories or paying people something different per hour. A lot of hospitals currently have, and ours does as well, have these clinical ladder programs, or really pushing for a lot of their nurses to get certified, or you know, and it puts them into a different group where they do have additional job responsibilities and role responsibilities. And so, you know, those kind of models are already in place. And so specialized models for maybe actual critical care and certain things like being an ECMO nurse or whatever y'all are calling it, or
Nurse,
you know,
nurse ECMO specialist.
or possible. But I think, again, there's going to be a group of nurses, like Katie said, and a lot of nurses, I feel like in general, have that go get them kind of, they want to attain the next level. They want to attain the next certification, or what else can I do to grow and expand their, you know, growth and knowledge. So a percentage of people would maybe really be interested in doing that and be a specialized nurse like that. But another percentage of them would be absolutely terrified and say, you know what, I just want to come and do my standard bedside
Yeah,
care.
but that's okay. I mean,
Yeah.
I think it's fine having a team. You have a heart team.
That's right.
You know, the operating room, we have the heart team. You have the neuro team. I mean, it's what floats your
Right.
boat.
Well, it's better for
know?
patient outcomes, for physician satisfaction as well. Do you have like a special team that you work with on a regular basis?
Sometimes.
Sometimes.
I think the development of the teams, I think you're right, the heart care team, the ECMO care team, and I think that when you become parts of that, I think it's good for retention for your nurses, and I think that it also, look, me having this conversation, and Dr. Skipper talked about this earlier, is making me at this point in time public enemy number one within my own profession, all right? So I'm sure there's a lot of people that are, you know, already burning me in effigy somewhere, and that's fine. You know, but it's an unavoidable problem. We get called constantly looking for, we've got ECMO and we don't have enough people, and we only have 2 perfusionists and we need to do ECMO and we can't cover it. Can you send us somebody? Well, no, I can't. It's not possible. And I mean, you know, and we just this past year had 6 ECMOs in 4 different hospitals. And we're a fairly good-sized group in this city. Even the med center runs out of space or people or beds or whatever it might be. So, you know, we were running out of people. We were this close to having to say, we cannot do that case tomorrow. We are all of our people are tied up doing ECMO.
So at the risk of being shot, I
By a perfusionist?
by any number of people.
It's Texas.
You know, I think there is another component to the nursing side when you start looking at how do you entice people into certain roles, and part of it is an HR issue. You know, there are some hospitals that won't necessarily let you pay an ICU nurse more money because they're covering CRRT or dialysis, because they're like, well, I'm sorry, you know, this staff nurse 3 is going to make the same amount of money working on the floor, taking care of patients who are ready for long-term discharge, as the person in the ICU who's a staff nurse 3 taking care of a patient on ECMO getting CRRT.
That's right.
Bleeding
So-
like heck.
But from an HR point of view, it gets very complicated.
And most of them are based on years of experience.
I do think your point of, you know, you would have to identify nurses that had that go get them attitude, and we've all seen, you can identify that within the first 2 days you work with someone as to what their
Work ethic,
well, no, it's not that.
Commitment.
It's how much they like challenges. It really is. And then the other question is, how many nurses does it take to staff a patient in an ICU 24/7, at least one-on-one coverage for 3 weeks, 2 weeks?
Well, I would add on to that oftentimes the people who would be willing to train to do ECMO, to take care of that, are also the people who are trained to do your open heart recovery, to do your CRT, to do all of the other high acuity tasks. And so it's
Spread a little
balancing
thin.
out the acuity of the unit with the number of staff who can handle that acuity.
Absolutely. And it's also balancing the number of staff required to do it with the ability to have adequate resources to maintain their competency and training, i.e. referred to as simulation type training and so forth, to make sure that you had enough adequately trained manpower to truly care for that patient.
Yeah,
So you would need,
It-
one or two nurses on every shift. What if someone calls in sick? So a number of contingency plans, but I think in a well-structured manner with the ability to have simulation training, one could keep a workforce up to speed.
I think
And I
it's
think
absolutely
having the
possible.
partnership, and I think this is where, this is very important ultimately for all of our success. And having that partnership and being able to say, okay, we're going to do it. But if you have the person who is going to watch it is in a car accident or has the flu and cannot do this, and you're having a staffing issue, the partnership with us, then we step into the role at that point in time. So you don't have to fear, I don't have someone that can care for this patient. And so I think having that ability to work together makes a big difference. Or if we're in the hospital and we're watching the ECMO, but a gunshot wound comes in, or stab wound like the other night, we had a stab wound the other night, comes in at the same time the person's watching the ECMO, if the nurse is at least comfortable with the circumstances, they can get down to the operating room, get that patient started while that call perfusionist is coming in, and not feel torn between should I leave, should I not, should I leave, should I not. The patient's stable. And one of the big things that I hear a lot from nurses is, what if something goes wrong? So this is something that I am very confident in saying. If something goes wrong, and it is of certain classifications of wrong, the only things that would really end up causing irreversible harm or trouble would be things that would cause that, whether I was physically standing there staring at it at the moment that thing happened. A connector gets knocked off and it breaks off, and there's nothing I can do. So the cannula comes out. Well, I can try to put it back in, but we'll all try together because it's not going to work out too terribly well. So there are just things, the catastrophic events aren't something, one, that happens very often. Fortunately, it does happen, but not often. You have to put safeguards in place to not let those things happen and understand how they can happen and avoid them. But having them occur is going to have the exact same outcome regardless of who is standing at the bedside at the time that actually occurred. So the other things that normally happen, like, the PCO2 is climbing, the saturation, the PO2 coming out of the oxygenator isn't as good, the CO2 is higher. I'm starting to see what looks like some gradu collecting around the top. It's not looking that good. Probably needs to be changed. Yeah, gradu, it's a medical term. It's a Louisiana medical term, gradu. Then I think that's when you just pick up the phone and say, hey, I think this circuit may need to be changed. And then we come in and we change the circuit and we go on our merry way. And that's the resolution to that. It's not really, you have to be right there. These things don't just fail acutely. But should they, it doesn't matter if I'm standing there or not. If it fails, it fails. There's nothing I can do.
So if there's a model that has, the other extreme, perfusion on one end, nurse/respiratory therapist on the other
I
end.
disagree with you on that. We're gonna have to discuss this. I totally disagree
I'm
with
helping
that.
you here. Go
Okay,
with
help.
me. Okay. But the model
we
exists.
disagree.
You can disagree with it or not, but it exists. I'm just acknowledging the existence.
The model exists, but I don't think it should.
So what I'm saying though is your worst case scenario of, okay, the circuit needs to be changed out. Mm-hmm. There are already models in place where clinical nurse ECMO specialists are changing those circuits.
Yes, absolutely.
So even the worst case scenario that Joe just outlined, is actually manageable with the right safeguards and the right training.
Training, that's the key, and practice.
And in the model that Joe's speaking of, you actually have perfusion backup available to come in and help troubleshoot things. So I'm actually helping you with that discussion.
Well, no, I'm glad you brought it up because I still have some technical questions I want to ask you. But go ahead.
No, one thing. So change is difficult. There's no question that it is very difficult. And so I'll give you an example of. I know you're on. I'm keeping you at bay. But one example was in our institution when the transition occurred from surgeons cannulating all the ECMO patients to non-surgeons cannulating them. So currently in my institution, essentially 100% of VV ECMO is cannulated by pulmonary critical care and or cardiology, depending on which particular cannula is used. Essentially 100% of percutaneous VA ECMO is cannulated by interventional cardiology and the cath lab. They place the retrograde cannulas for VA ECMO. They place the antegrade stick with it going down the superficial femoral artery. And we actually made that transition because it made sense. Now, the first patient that I had cardiology go cannulate for ECMO was actually in our cardiac ICU. And the intensivist for the unit grabbed me in the hall and said, "Do you know what's getting ready to happen in there?" I said, "Yes, I do. It's my patient." He goes, "Well, what are they doing? They don't know what they're doing." I mean, they put catheters in arteries and veins all day long. They do antegrade sticks for. I go, "What do you mean they don't know what they're doing? They do this very well." And they actually were very receptive and very enthusiastic. I was very receptive because that meant that they were doing it at 2 a.m. and I wasn't. But actually, they were doing it better because what was happening, oftentimes patients were being taken from the cath lab to the unit or to the hybrid OR or to a regular OR if the hybrid room wasn't available. And these catheters were being placed with ultrasound rather than fluoro, angio, or the absolutely. And so it actually, change was interesting, but it made sense in so many different levels. And I think that's where revisiting these models, looking at what change makes the most sense, and how do you affect that change for the patient's benefit, is absolutely of necessity.
So. I think all of those are very good points. And there's very many more of them in your business, cardiology, than you. Just like in our business, there's many more of you all nurses than there are of us. I mean, this is really a matter of just numbers and math and ability. I mean, that's all it really comes down to. But I wanted to break what Dr. Skipper keeps alluding to, which is really getting on my nerves. Has to do with nurse ECMO specialists. And so perfusionists automatically, just by what our training is and our certification through the American Board and all this kind of nonsense, we can manage ECMO. That's just part of what we normally do. The nurse ECMO specialist, really any nurse, can manage ECMO. They don't have to be a nurse ECMO specialist. But in the big wide world out there, there exists both nurse ECMO specialists and respiratory therapy ECMO specialists. And albeit I believe that respiratory therapists are very smart people and very, very capable people, and certainly very capable of learning, I don't think that they have the same perspective and experience in managing, pressors, inotropes, bleeding, fluid shifts, all of the other aspects of a patient that ECMO so eloquently affects. And so even though I think that they understand the pulmonary system very well, I think they understand the ventilator very well, I think they're experts at that, I think ICU nurses, in my opinion, are much better equipped to manage an ECMO circuit than is a respiratory therapist. I mean, it's my opinion, right, wrong, or indifferent. But he keeps bringing it up because it is not uncommon. And I think, though, the thing that illustrates to me is that and I hope if there's any respiratory therapists watching, I'll apologize in advance, but if they can do this, it's not real hard for me to imagine that someone who is managing 4, 5, 6 IMED pumps with Levo, Neo, Vaso, Epi, Primacor, transfusing because the chest tubes are putting out, 250 an hour, giving albumin, shocking them every once in a while, doing whatever other resuscitations that you need to do, and managing, everything, the balloon pump,
Don't forget all the charting.
the CRRT, the charting, the patient satisfaction scores, getting their dietary needs met, asking, giving them a menu. But
They're not.
it's important. If you can do all of that, it's changing the bed. Yeah, changing the bed. It's real. Doing oral care.
Oral care.
I said oral care. Okay. I mean, I'm not going any further than that. But if you can do all of that, it's sort of hard for me to imagine that you can't do this. It's. I think there's this fear, but I think the fear is somewhat exaggerated. And I think if you take that fear away and make it more of it's a device, it's a machine, it does this, then I think that's a
Troubleshooting, like a troubleshooting guide.
That's what it is. It's all it is. But the system has to be built in a safe manner. The device itself can't be, fraught with landmines all over the place that can create problems for you of their own. So it has to be a very simplified system. It may not be a system that you can easily plug a CRRT machine in, but it will be a safe system. And again, I think we all have to be a part of a solution to a big problem. I do have some technical questions, though.
Should I distract him again?
One of the big criticisms of you put a patient on ECMO and they do real well, and you get the patient off ECMO, and everybody else huddles around and says, the patient probably didn't need it anyway. Criticism one. A lot of people wait until it's too late before they put the patient on ECMO because they're afraid of that criticism. How do you address that?
Well, they're clearly not heart surgeons, or they wouldn't be afraid of that criticism. So, look, there are people who are Monday morning quarterbacking everything you do. And when it works out well, they're very happy with things. When it doesn't work out so well and it costs them money, they're not happy. I think in the end, you just have to do what's right. And as you saw, sometimes earlier intervention is better. There's a reason that post-cardiotomy failure in the adult cardiac population has better outcomes than some of the other options. And that's because the patients are recognized early, they're set up for success. And I think as long as you're doing the right thing and you have the patient's interest at heart and you're not doing things that are ludicrous. So if you're putting people on ECMO and the team, the neurologist, the neurosurgeon, the intensivist are all telling you, we have nowhere to go here. There's a major bleed, blah, 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 and it takes you a week and a half to take them off ECMO, you're going to get a lot of that. But as long as you're approaching things in a rational manner and you're really trying to do the right thing for the patient, then I think you can ignore that criticism.
Now let me make some other people really mad. What do you think about having some type of a committee, a group of some sort, small, maybe just one person, who is the ultimate arbiter of whether or not a patient is put on ECMO or not? Is that a reasonable thing? Is that something that you see to avoid just what you discussed?
So I think in my institution, we have the closest thing to that you could have. So we have a medical director and a team of individuals that do the daily ECMO management. They're by and large critical care physicians. One's a surgical critical care doc. The others are all pulmonary critical care, ED critical care. But there's a group of about 4 or 5 that manage. And there's one medical director for those individuals. We have heart failure cardiology involved if there's a cardiogenics reason involved. And we have CT surgery involved if there's a need to have that collaboration. Also, interventional cardiology if it looks like it's a VA ECMO candidate. All discussions for ECMO go through the point person who is covering the ECMO team that day. So there's at minimum a 2 and usually a 3 physician discussion about the appropriateness of ECMO and where we're going with this. There's at least 2 or 3 sets of eyes looking at each patient and where we are. The one-offs of that are post-cardiotomy failure because you're in the OR, you're either coming off pump or you're not. The risk profile for the patient was certainly good enough to take them to the OR. So there's not a lot of discussion other than we're going to ECMO and we're going to come out on ECMO. But I think for most everything else there is discussion. There's discussion on patients that are being accepted in from our hub and spoke model for ECMO. Before they're ever accepted, there's discussion between the ECMO management team, the critical care team, and heart failure cardiology or the accepting physician.
We just had that happen, right, with a patient from further up north from one of the CHI hospitals. They sent him down to us, and that patient ARDS, pneumonia from influenza, and he did real well. He did really well. So I was happy about that. Didn't have to go all the way to the med center, but we did take care of a lot of people out in the community hospitals here.
But a collaborative approach is key. And I think that's your point.
Yes, I think that's one of the big problems we have here is that nobody is in. It's the Wild West, and so everybody just I've decided this, and so I'm going to do it, and there's nobody saying whoa, hold on,
Checks and balances.
Let's talk about this for just a second. What does this patient have any chance of long-term survival, really? But that brings up my next point. I had an intensivist in Alexandria, Louisiana. I won't say his name and embarrass him, but he told me point blank, just he didn't even blink. Okay, he didn't even flinch. ECMO has never saved anyone.
Everybody has an opinion.
I never said his name.
ECMO in and of itself may not save everybody, but it is a support tool, just like a balloon pump, just like multiple drips. So, and if you have a patient who is going to come out of the operating room on 3, 4, 5 drips, plus minus a balloon pump, with borderline urine output, who's going to be high risk for renal failure. Supporting that patient to get them through the immediate crisis is going to help assist them in surviving.
But I want you to highlight that one point that you made earlier as well. The point about ECMO is there to buy you time. It's a support tool, but you have to fix whatever the underlying problem is. I think that's going to be my takeaway message for this evening.
Well, you need to apply the appropriate principles for pulmonary rest. So you don't want to maximally ventilate the lungs, over pressurize the lungs while you're on ECMO. It's not going to do you any good. You don't want to let the RV be overloaded. You want to make sure you have appropriate venous drainage. If you place that venous cannula so that the tip of the cannula is in the IVC right atrial junction versus 2 centimeters up the SVC, your drainage isn't going to be as good. You, in the OR, with vacuum assist, could probably drain that patient adequately. But in the ICU, on a standard ECMO circuit, there's going to be a lot of volume in that right
gonna
atrium going into the
bypass.
RV, your LV is going to be distended. You really have to make sure if there's not adequate LV contractility that there's some other adjunct to decompressing the LV. Otherwise, you're not setting the patient up for recovery. You're setting the patient up for continued failure in spite of expensive ECMO support.
Very good. Well, I want to thank everybody for this evening, starting down with Kara and Katie and Dr. Skipper and Kristen, and of course, I'm your host, Joe. I will see you. Oh, yes, Roger just said make sure you subscribe if you haven't already done so. If you have done so, thank you very much. If not, do it. Do it early, do it often. We'll see you in 2 weeks with our program, which is going to be Dr. Badia coming in talking about validating graft patency. And he's got a really interesting case that I did with him where I know he says this never happens, but he took his graft down and redid it. And you all are going to get to see it right here.